welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Tejas Shaker. He is a graduate student and he wrote the Kevin MD article, Inhaler Non-Adherence and Social Determinants of Health. Tejas, welcome to the show.
Thank you for having me.
We'll get into the article in a little bit, but first off, can you share your story and journey to where you are today?
Sure. So I graduated from Northwestern University in 2020, and I'm now a graduate student wrapping up at Washington University. And I'm an aspiring physician, and I also do some research at the intersection of social health, health disparities, asthma, as well as COVID. So a couple of different topics that are under my belt.
Wonderful. And regarding that intersection with your research, tell me how you got interested in that avenue.
So I've always had a long-standing interest in social equity and social determinants of health. And being a student at the time, when everyone was being sent home during COVID, I found a lot of great opportunities back home here in St. Louis to get involved with research. And through Washington University School of Medicine, there were a couple of different avenues that opened up for me. So I jumped on board to do COVID testing, to interview patients during contact tracing and provide help with those efforts, as well as I got involved with the pulmonary and critical care department to learn a little bit more about asthma, as well as do some mixed methods interviewing patients during that as well.
All right, so let's talk more about that intersection between asthma and social determinants of health. It's in your Kevin MD article about inhaler non-adherence and social determinants of health. Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Sure. So as I started interviewing patients and providers for my research with asthma, we are essentially interested in learning more about provider and about stakeholder perspectives of asthma, as well as latest recommendations that have come out from different governing bodies on asthma. So GINA, EPR4, they've released latest guidelines about new recommendations that can be done to combine maintenance and rescue inhalers into one form. And with those recommendations, we're seeing that these better reflect what the patient population is currently using. So a lot of times patients are forgetting to use their maintenance inhaler for these mild to moderate asthma patient populations, and they just end up using their rescue inhaler chronically. And that is an issue for a couple of reasons. It bears on their costs, it affects their refills, their insurance. So what we're kind of seeing here is that these governing bodies, GINA and EPR4, have sort of adopted and understood patients to be utilizing only their rescue inhalers essentially, and to ensure that patients are also being exposed to an inhaled corticosteroid as with their maintenance inhaler, they've essentially combined these to create budesonide formoterol combinations, these combined ICS-LABA inhaler combinations that, again, better reflect what patients are actually doing in practice and are being able to deliver them in ICS as well.
So tell us about some of the reasons why sometimes patients just rely on more in their rescue inhalers rather than that maintenance steroid inhaler. What are some of the obstacles that prevent them from going that route?
Right. What we're seeing from a lot of these interviews with patients is that oftentimes they just forget to take their maintenance inhaler. If you think about asthma as being this chronic condition, you have all these varying demographics. So some of the demographics that are involved are patients who might have comorbidities of dementia, or our younger patient populations who aren't necessarily taking inhalers or any sort of medication on a daily basis. So for both of these populations, inhaler maintenance is a difficult thing for them, especially with those maintenance inhalers, because again, they don't necessarily feel the effects of it, or they forget about the effects of it because they might be feeling fine for a day or two. But when you're in an acute situation, you always remember to take your rescue inhaler because you experience that flare, you experience the symptoms. But with forgetting to take a maintenance inhaler, you might not feel those effects from one day to another day. So that's what we're kind of seeing as some of those issues, as well as some sort of integration with their lifestyle as well. Maybe they might be in a rush in the morning, or maybe they have something in the evening that they might forget to set aside a time aside to actually take that maintenance inhaler, again, for the reasons of maybe not feeling those symptoms when they're, again, a mild or moderate asthmatic patient.
Now, can you comment on the effects of cost? I think when I ever talk to my patients regarding prescribing a long-acting, a maintenance inhaled corticosteroid, or even now these albuterol inhalers, the cost of these inhalers sometimes are prohibitive for a lot of patients. So, what does your research say about cost of these inhalers?
Yeah, what we're seeing here is that, it really depends at the end of the day on the patient's insurance formulary. Whether or not that inhaler is covered by it essentially is the reason why or why not a patient will use an inhaler. And this reflects a difficulty for providers as well, as they constantly have to adapt to what these patients' insurance formularies are and their different insurances. So they can't necessarily always have a standardized practice from patient to patient, even within similar social determinants of health, such as SES or geographical location. Those things kind of somewhat go out the window when you have to consider that formulary as being kind of the gold standard. But in addition to that, what we're seeing is that, as you know, inhalers are expensive, but the combined approach might be more effective in the long run. Because if you think about these patients who are not taking their maintenance inhaler, and they might be using their albuterol or their rescue on a more chronic basis, that significantly drives up the price point, because if they're not actively managing the condition over the long term, they might be seen at the emergency department, for
Mhm.
example, when they experience a flare up that their albuterol can't necessarily handle. And if you do a cost benefit analysis in the long run, which is something that we're doing, we see that these patients are actively spending more, even with the coverage of their insurance. So this combined approach, getting a maintenance inhaler kind of in the mix here, getting it actually into the patient's system and ensuring that they're using some sort of steroid or ICS, that effectively brings down the cost in the long run, even though in the acute moment it might seem that this might be a more expensive option. But again, once you average that out over longevity of how often patients are actually having asthma using their inhalers, it ends up being a lower price point for them.
So, just to be clear, tell me about what the new recommendations are. So, are you contrasting a inhaled corticosteroid maintenance inhaler with a combined long-acting beta agonist slash corticosteroid inhaler? What's the data points between those two routes?
Right. So what we saw in the data here with GINA coming out with recommendations in 2019 is that you have the traditional approach. There's the general step-up therapy, which is completely fine and advocated for. That is something that a lot of providers are still using, where you have your separate rescue inhaler and your
Yeah.
separate maintenance inhaler. But what GINA is advocating for, because a lot of the patients again are forgetting to actually use that maintenance inhaler for a number of reasons, is that if you get something like Symbicort, which
Hmm.
has a combined budesonide formoterol basis, that's a way of getting that inhaled corticosteroid into the mix, because otherwise patients effectively aren't using it. So that's kind of the new recommendation, what we're seeing with GINA.
And then that medicine like Symbicort combined, that's going to be used on an as-needed basis?
Exactly, yes, it's on an as needed basis, even though what we're seeing as well is there are some discrepancies with it being an off-label use, because even though GINA and other regulatory bodies are advocating for this, it's still not an FDA, prescribed use, even though it's been used for similar indications. So it's technically off-label, but
Hmm.
that's again one of the challenges that we're kind of seeing with interviewing these providers and how they might be able to write the script to in order to get the patient to use Symbicort on an as-needed basis.
Just from your experiences with interviewing various clinicians, how many approximately are using those combined inhalers as you mentioned just now?
Yeah, that's a great question. It really varies in what we see. We see some interesting trends across academic medicine versus community medicine. A lot of times we see maybe within academic medicine where providers are reading upon these guidelines a little bit more actively, and they might have a more relaxed patient population or a more mild to moderate patient population that isn't kind of seeing tons of specialists with an outpatient setting. We're seeing that these providers might be a little bit more inclined to get into the mix here to use that new GINA updated guideline and to use that combined inhaler. But that's not to say that community providers aren't using this at all. It's just that because they've been more set in their ways, because they're a little bit more disconnected from the guidelines that are coming out for barriers to access being some of these issues, we see that they're a little slower to adopt this, or a little bit more reluctant or hesitant to adopt this, with good reason, good understanding for that, because again, what they see in their patient population is ultimately what matters. If they have a patient that already works with their current strategy, there's no reason necessarily to shift their strategy. This is again better for patients with mild to moderate asthma who are maybe a little bit more non-compliant or have a couple of other comorbidities that tend to make them forget to use this maintenance inhaler.
So you mentioned GINA a few times. For those who aren't familiar with that organization, can you tell us a little bit about that?
Yeah, so GINA, they are one of the largest governing bodies of asthma regulations. So they push out guidelines every now and then, but they usually have an annual conference every year where they provide updates to the field of asthma. So, yes.
And GINA being short for the Global Initiative for Asthma, correct?
That is correct, yes.
All right, we're talking to Tejas Shaker. He is a graduate student. He wrote the Kevin MD article, Inhaler Non-Adherence and Social Determinants of Health. Tejas, what are some of your take-home messages that you want the Kevin MD audience to come away with?
Yeah, so I think relating this back to my interest in health equity, and again, with the article being titled about social determinants of health, I think it's really important for everyone involved here to step back at the end of the day and really think critically about that. As we're thinking about these social determinants of health, we might label certain patient populations as being non-adherent or even non-compliant for reasons that aren't necessarily related to disposition. For example, you might think of a stereotypical patient who's difficult to deal with, but the reality might be a little bit more complex than that and a little bit more multifaceted. It might be for reasons due to insurance coverage, as we talked about, or due to the inability to pay, or a number of other reasons. Maybe the pharmacy is too far away from their house, or maybe they have a ton of other factors going on in their daily life that adding another thing like a daily asthma inhaler to use might not be the right fit for them. Maybe they might require some sort of other intervention. So I think as we think about non-adherence, we need to think and continue to research the reasons for why this might be the case without stopping the ball at just the level of the patient's kind of involvement here. We have to think about the reasons that go and extend beyond that.
Tejas, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you.